Today on Sarah Has Questions, we're talking about something that if you are over the age of 45 and have an Instagram account, you are being berated with messages about, and that is hormone replacement therapy. But we're talking menopause hormone therapy today because it is a specific type of hormone therapy. And it got a bad rap at one point, so is it good for you? Is it bad for you? Well, we're going to talk to the doctor right now and find out. I'm Sarah King, and I have a lot of questions. In this show, I get to ask WakeMed doctors any question I want, and bless their hearts, they have all the answers. Sarah Has Questions is a production of Mix 101.5 and Capital Broadcasting Company, and it's presented by WakeMed. We have another veteran of Sarah Has Questions here. It's Amantia Kennedy, who is a gynecologist and obstetrician with WakeMed. Welcome back for your fourth time.
Thank you.
You know, the next time we're working on getting robes.
I know, right? The fifth time.
Yes. SNL can't be the only one doling out a wardrobe for coming on. So we're talking about a real hot topic right now, and that is HRT. I actually heard, so HRT is hormone replacement therapy. And I actually heard that just like Ozempic, because it's getting more popular, there's starting to be shortages. Is that true?
That's true.
That is crazy. I mean, I think it's great.
I think so too.
Yeah. But
we're going to dive into that.
Oh, yeah, we're getting in there for sure. So let's just start at the beginning. HRT, hormone replacement therapy, how long has it been around?
It's been around for a while.
Okay.
The very first time that we invented synthetic estrogen was in the 1940s.
Oh, wow.
Yeah. But we actually made it and found that we can make it even in more in batches and in the 60s and through the pregnant mares.
Oh, horses. Interesting.
Yeah.
So I know... I mean, that's a lot longer, to be honest, than I thought it has been around. But I know it got a bad rap in like the 80s and 90s. What happened?
Actually, it got a bad rap in the 2000s.
Oh, is that? I just remember it in the past.
But we can go over the past because unless we see the past, we can understand the future,
Sure.
Right?
Okay.
So in the 80s and 90s, we were giving hormones to everybody. Same dose, everybody, all comers, because we believed that hormones, especially estrogen, is protective against chronic disease like cardiovascular disease or bone fractures.
Okay.
So then as the 90s came along and we were trying to get more studies, they started the Women's Health Initiative.
They being the government.
The research study, yes.
Okay.
A larger multi-center study that we developed. And it was the most expensive study ever on women specifically.
Wow.
Like we're talking about $800 million back then.
Oh, wow.
And it was a randomized trial. So it was really, really good. But what they were trying to see, they wanted to prove that estrogen was cardioprotective. It prevented cardiovascular disease. And what happened is that as a secondary outcome, as they were doing those studies, they noticed that, wow, those women that are exposed to estrogen and progesterone hormone therapy, they actually had more breast cancers. So then, instead of looking back at the study and analyzing it a little bit farther, before that, they took it to the media.
Oh, so they didn't go back to see maybe if their sample was wrong.
Correct.
Oh, interesting.
So we went from everybody needs estrogen to now nobody was touching estrogen in 2000s.
So did they figure out why they got that result? Was it a skewed result?
It was, as it turns out.
Oh, why? I mean, I know this, just quickly, why was it skewed? What got skewed?
So what happened, as I mentioned before, is that they included a wide range of women from 50 years old to women from 70 years old.
Okay.
And the average woman entering that study was in mid-60s. So we know that and these women were taking estrogen or hormone therapy for the first time in their lives. And we know that now, based on once we went back and reviewed the data, we know that giving women that are older hormone therapy is actually not safe.
Because so there's an age time.
Correct. So timing is of matter. So we went from everybody on hormones to nobody on hormones for 20 years plus to now more evidence-based,
right,
to individualized treatment, to when you need it, for what you need it for, and the regimens are different as well.
Okay.
It's not one size fits all.
Right. Well, that's great. And I the more I do this show, the more I realized medicine in general is kind of going in that direction, which is great.
It is.
So how is, well, I think you kind of told me, how's the conversation of HRT shifted culturally? Why are women more talking about it more openly now? And I guess that really means is, I remember my grandmother would talk to my mom about it in hushed tones.
Yes.
They're going through the change.
Silent, yes.
Yeah. So why do you think people are talking about it more openly?
Well, I think that women are talking, especially social media has a lot to do with it. But I think that once we start talking about it and recognizing that, wow, wait a minute, this is not just me. These are not, it's not in my head. I'm actually struggling because everybody experiences symptoms of menopause differently. And so once women saw that, hey, we're in this together, like there's some changes that are happening to our body that nobody is talking about.
Yeah.
And as I've mentioned before, the longer we live, average women living in the United States is age 84. We spend 40% of our lifetime in menopause. I mean, that's a big chunk of your life to be going through changes and not knowing why.
Yeah.
And suffer in silence.
Yeah, absolutely. Well, what are the biggest misconceptions with hormone replacement therapy?
There's a lot of misconception, and I want to mention that while social media is a good thing that has happened to us as women because we're taking the conversations to the table and where it matters, there's also a lot of misinformation out there. So buyers beware.
Yeah.
In our medical field, we practice evidence-based medicine. So if somebody comes to me, I based my counseling based on the studies that are actually good studies that actually show that there are benefits, because in anything you have to weigh risk and benefits. One of the misconceptions, and it came from the WHI study, was the breast cancer.
Right.
Some women think that all hormones cause breast cancer. And I want to emphasize that not all hormones cause breast cancer. We have studies that looked at particular different types of hormones. The biggest study compared estrogen and progesterone hormone therapy versus estrogen hormone therapy. And it was only slightly increased risk for estrogen and progesterone arm. But that was for synthetic progesterone, and we have different types of combination now. So it's not the same as it used to be.
Okay.
That's why, and we can talk more later on about different types of hormones, why physicians choose different types of hormones for different women for different symptoms.
Okay. And you mentioned a minute ago that there's like a window that you need to give the estrogen, and then I'm assuming you have to take it away at some point.
Well, not always.
Okay.
It's individualized, just like I mentioned before. Just because you have been on hormones, if you started at the right time, and usually now the consensus is if you started less than age 60 or within 10 years of reaching menopause, you can start it, you can continue it, and every year we assess the risks, the benefits, the goals, and you can either decide to continue based on what you know, what your goals are, or you can decide to discontinue, because the purpose for us giving hormones right now, and I want all women to hear this, is for the symptoms of menopause. It's not preventative. The indication is for symptoms of menopause, like brain fog, fatigue, mood, irritability, hot flashes, night sweats, things like that.
How do you know when it's time to, if someone needs to be taken off of it?
Well, if a woman decides that her risks are, every year, like I said, if she's developing cardiovascular disease, or if she's developing other chronic conditions that may adversely be affected by adding estrogen, then she can decide to discontinue.
But that's not because she's not developing these things because of the HRT. These are just
No.
something she's developing.
She's developing. Everybody has different risk factors. Just because you are on HRT doesn't mean that you are not. You may not develop chronic diseases.
Okay.
But it's an individualized approach. You can be. According to the Menopause Society now, we recommend the hormone therapy, and now the HRT is replaced with menopause hormone therapy. That's what we call it.
Okay.
For the shortest amount of time to help with your symptoms. But that's not based on real data. It's just that's what the Menopause Society came with the statement. But you can continue them if you want to. Now, women that it's different to come in at your mid 60s and say, I want to start the hormones, like the beginning, the WHI, from somebody that has been on hormones since menopause.
You can't shock the system, basically.
The risks are different.
I see.
Because we know that the women that started early, there may be some protection there. We don't have the robust data on that, but we do know that women do better if we start early on. So it's a different risk factors. And so a woman that has been on hormones and she's in her mid 60s and she wants to continue on hormones, it's okay to continue on them. You don't have to discontinue. But the difference and the misunderstanding from the public, from the social media, is that everybody is a candidate for hormones.
But that actually takes me to another question. Are there any women who are absolutely not, you said people that would want to start in their 60s. So are there women that actually should not take HRT? And if they can't take it, are there alternatives for them?
Yes. So there are a particular group of women, especially women with breast cancer, that are estrogen, progesterone receptor positive. They are not candidates for systemic hormone therapy. And that's an absolute contraindication because they're on medications to block the estrogen production.
So do you only know if you are, what did you call it, estrogen receptive?
Estrogen and progesterone receptor positive.
So can you know that before you develop breast cancer?
No.
So you have to get the cancer in order to realize you are this way.
Correct. There's different types of breast cancers.
Yes.
Some are positive, some are negative.
Oh, interesting. Okay. So if you have breast cancer and you are the type that estrogen's making it worse, you can't take HRT.
You cannot take it. That's an absolute contraindication.
Right. Okay. And so what you said, I asked you if there are alternatives.
There are alternatives. And it goes back to what I was mentioning before. We're trying to treat the symptoms.
Yeah.
Right? So there are the neurokine 3 antagonist medications, the newer medications in the market that actually block that particular part of the brain that is the thermoregulatory, and it promises up to 80% reduction in hot flashes.
Oh, wow.
So there are options.
Okay,
there are
great.
other options. I want to also emphasize that menopause is not a disease.
Thank you. I'm so glad you said that. It does feel like one, though.
It can feel uncomfortable, but it's not a disease. And I think we need to emphasize that because we used to gaslight the women in the past.
Yes.
All women. And I don't want to gaslight them again and say you need hormones because not everybody is a candidate, but also some women don't want to be on hormones. And that's okay. We have to respect that wish as well.
Oh, for sure. Yeah, for sure. So now I want to talk about the applications, how they come across. I'm on HRT, as you know. Why does HRT come in a sticker? That is the only medicine I've ever seen as a sticker. Why?
Okay, so that's a good question. And as I mentioned before, we have different types of combination. And when you talk about a sticker, you mean a patch.
Well, you're calling it a patch, but if I had a sticker book, I could also stick it in my sticker book. Yeah.
Yes. When we develop hormones, there's different kinds of, it can be oral hormones, transdermal hormones. The reason why I prefer the transdermal route is because when there were studies, it showed that transdermal bypasses the liver metabolism, so it has less risks for DVTs or deep vein thrombosis.
Deep vein thrombosis, okay.
Because when you take an oral estrogen, it is metabolized in the liver.
Okay.
Liver is the organ that produces these clotting factors, like the factors that are responsible for making sure that you don't bleed to death. But when you take estrogen, these clotting factors are increased. So your risks are slightly higher.
If you take it orally.
So that's why a lot of us, me in particular, prefer the transdermal route. And then we separate it with progesterone because remember progesterone, we need to have it for women that have a uterus.
Yes. I actually heard social media. Thank you. Social media. I watched a video saying it has something to do with the lining.
Correct. So estrogen, think of it, I always, the analogy that I give is the lining of the uterus is like bricks on a wall. Estrogen puts these bricks on this wall. And then progesterone is the mortar of those bricks. So it stabilizes that wall. So if you have unopposed estrogen,
which means estrogen with no mortar.
Exactly. Then you're going to shed it irregularly. And then over time, you have increased risk for developing cancer.
Interesting.
Of the uterus, yes. Endometrial cancer. Mm-hmm.
But I also hear that, and by the way, I take progesterone as a pill, not a patch.
Yes. So the reason why that's why sometimes if you have to have progesterone, there's different formulations of progesterone as well. It can come in a transdermal patch, yes. But we give micronized progesterone because it's a bioidentical hormone. It's a molecule that is identical to your own progesterone.
Okay. We love that.
We love that because it crosses what we call blood-brain barrier, and it acts as on the receptors that help us with mood, and it helps us with sleep because it relaxes us. So for women that have difficulty sleeping, that's a symptom. Then I prefer the micronized progesterone for that reason. In addition, when compared to other formulations of progesterone, like the semi-synthesized progesterones, in some studies, it showed less risk for breast cancer compared to other progesterones.
Okay.
So that's another reason
why you do what you do.
Why I prefer that as a beginner.
I just wonder if because I know not all doctors, everybody's different. Human nature gets tied in. You really do read a lot of studies. Do all doctors, would you say, have you come across some? And please don't name names, although you can if you want to get spill some tea. But do all doctors, are they so well researched as you?
I don't think so. And it's not because I'm special or anything. It's because the interest, my interest is in menopause.
Yeah.
So I really want to be up to date with everything menopause because I want to serve my patients because I have a large population of patients that are in menopause and they come to me for treatment. And I want to respect that, and I want to be able to educate my patients. But not everybody, even in the gynecological world, not everybody's interested in menopause. So I always say, look, it's okay. It doesn't make you a bad doctor. That's not a field that you may be interested in.
Sure.
And so find somebody that is interested, that is going to answer your questions, but that you understand.
Yeah. Well, I think it's interesting that we have OBGYNs and gynecologists. Why can we not have, since women's lives really are in 3 sections, or 2 sections rather, why don't we have gynecologists, OBGYNs, and then, another term for menopause specialists so you can have the initials so just by looking at the business card that you're a menopause person.
Right. But remember, as we spoke earlier, menopause is just now catching on.
Oh, I know.
Only the past 3 years, really.
Isn't that insane?
It is insane. But I'm glad that it has.
Oh, yeah.
But I think that it's just everybody is just learning as they go. And as I mentioned before, and I don't want to name names, even on the social media, some are very well liked, even in multiple talk shows, and they sound really legit. But if there is an agenda, if somebody's trying to sell you something, because sometimes even information on social media may be presented as information, but it has a meaning behind it. I'm trying to sell you something. So just be aware of those posts.
Almost, I get what you're saying. All right, back to the HRT. Do you need blood work to get the correct formula for that?
No, and that's another misunderstanding. And I saw before I came here, I went into the social media to also see what's out there. And I was like, oh my gosh, this is ridiculous. So we don't, because as of now, we only treat the symptoms. So we start with the lowest dose, and then we adjust the dose of the medication based on how you feel. Because some women can respond fine with low levels of estrogen. It's physiological. There are some things that we don't understand why. And then there's some women that need higher levels to respond at the same degree.
Okay, and so that was my next question. How do you know you have the wrong dosage?
Because you don't feel have the symptoms resolved,
Yeah.
or you don't feel like yourself. So I have a lot of times women will come in. Usually once we start you on a hormone therapy, we have you come back to see how you're doing, and then to see if we need to adjust anything. Now, sometimes, as I mentioned, there's different formulations, and I want to explain a little bit about it because there's some misinformation out there. When some hormone is sold as natural, what natural will tells you is just that it comes from nature. It doesn't tell you anything else. Then there is the bioidentical, which means that the molecule is the same as your own natural molecule, but it may or may not come from nature. And so there is a difference, because a lot of times the compounded formulations out there, they bioidentical, get this test, it's going to mimic we have that already. We have the bioidentical. The micronized progesterone is a bioidentical hormone.
But is it natural?
It is natural, actually. It comes from yams.
But does it matter?
It doesn't matter, though.
Oh.
So even if micronized progesterone is a bioidentical. It comes from yams and soy plants. So, but it is semi-synthesized in the lab, and now it's a bioidentical.
Gotcha.
And estradiol is the same way. It's bioidentical, but it's synthesized in the lab.
From what? Do you know?
From yams and
Still yams.
Yeah,
That's
and soy.
interesting.
Yes.
Well, does that mean if I eat a yam, I'm getting estrogen?
No, that's another thing. No, you can eat a lot of yams and you are not going to get the amount of estrogen, because again, they get it. They synthesize it and semi-synthesize it in the lab to get the amount that you need.
What about soy?
The same thing.
Oh, okay. Are there lifestyle factors like diet, alcohol, stress, sleep that can interact with the effectiveness of HRT?
Yes. The answer is yes.
Okay.
And lifestyle, a lot of times women, as they transition into the perimenopause and menopause, are more at risk for developing insulin resistance and weight gain, inflammation, type 2 diabetes. And that actually counteracts the effects of the HRT. So lifestyle matters. Just because you are on hormone or menopause hormone therapy now, it does not mean that you're going to lose weight, you're going to have your youth or anything like that. The expectations needs to be set realistically. We are trying to minimize the symptoms and optimize your health, but you also need to have the lifestyle changes. You need to be checked for insulin resistance. You need to check your cholesterol. You need to be up to date with your mammograms. You need to be up to date with your lipid profile so that you can understand your risk factors and then adjust them accordingly. Don't smoke. Avoid too much alcohol. Weight loss is important if you are overweight, because that increases your risk for breast cancer even more than hormone therapy.
Why is that?
Because it causes inflammation, insulin resistance, that causes abnormalities in your cell production.
Wow.
Inflammation and cortisol, you have to have a good night's sleep, because like restless nights or stressful nights increase your cortisol levels, which in turn keeps your body inflamed.
Wow. It's hard being a lady.
It is.
All right, we have one listener question.
Okay.
And I think you kind of already answered it, but let me see. I know that with Hashimoto's, there is a choice between a hormone derived from a pig and a synthetic version. Is this the same with HRT?
So, no. Yes and no. It's not a simple answer, but let me just go through the thyroid hormone. Armour thyroid comes from pigs' thyroid glands.
Okay.
And usually it comes from pigs that are in the food industry, right? So they just take their thyroid and then they process it to give you the hormone. The levothyroxine, which is a synthesized bioidentical hormone, but you can choose. Some people just feel ethically, compelled not to use the thyroid, Armour thyroid that comes from the pig's thyroid gland. And then some women don't want conjugate estrogen or equine estrogen, CCE, Premarin, that comes from the pregnant Mars. It comes from their urine. So those are estrogens. They're not bioidentical because they're different types of estrogens that your body doesn't make, but they still come from the urine of a horse.
Well, I know a friend of mine she has Hashimoto's, and she has to be on the pig one because the synthetic doesn't work for her.
Right. So everybody reacts differently, how their receptors are. So it's just a different.
Just keep the dialogue open is what I'm hearing with these hormones because they're so specific to the person.
They are specific. And that's why I said in the beginning, hormone therapy now is more individualized.
Yeah.
Because there are situations, because you would say, well, why would I want synthetic hormones if you're telling me that micronized estrogen is good and this is good? Well, not everybody absorbs it at the same rate.
Exactly, yes.
I have women that are on micronized progesterone, which I like. It helps with sleep. But they're having breakthrough bleeding a lot.
Yeah.
And even if I adjust the dose, if they continue to have breakthrough bleeding, then I know that I don't have the right protection. Maybe they're not absorbing it correctly. So maybe a stronger progestin, which is a synthesized progestin or progestin-like molecules, may be better.
Okay.
Because they're more potent. They have a different receptor activity.
Yeah.
So that could be prudent. Somebody that has endometriosis, they may need a little bit more protection. So I would adjust the medications according to their needs.
Your job is so complicated, but I'm so grateful you do it.
Well, thank you. I like it.
All right. Well, thank you for your time today. This has been fascinating.
Oh, good.
Yeah.
I'm glad.
And we'll have you one more time because we got to get you a robe.
Yeah, I need the robe.
I am so grateful that doctors like Amantia Kennedy exist that do their homework and realize that women spend 40% of their lives in menopause, and we deserve to be comfortable and healthy. Thank you so much to Dr. Kennedy today for coming on the show, sharing what she knows, and letting us go forward a little more informed with what we need to do. If you like the show or know someone in menopause or getting ready to head into menopause, send it their way. Like we said, we've only been talking about this for 3 years, so spread the good, real information far and wide. Thanks as always to WakeMed for making these podcasts possible, and we'll see you next time.